Diabetes Damages Part 1, number 1593, the 9th of April 2026, Gerald C. EclaireMD Foundation, Category Diabetes. Abstract, it appears that diabetes may function as a root cause for many major mortality diseases. This statement is not absolute or universal, but it is largely correct when examined from a long-term biomedical system perspective. Type 2 diabetes (T2D) is not always the direct cause of death. However, it often serves as an upstream driver or root cause that gradually increases the probability of multiple downstream diseases. In plain language, diabetes quickly damages blood vessels, nerves, and organs over many years. This slow and continuous damage increases the risk of developing several high-mortality diseases, including cardiovascular disease, stroke, chronic kidney disease, dementia, and certain cancers. The underlying mechanism involves long-term metabolic imbalance, vascular deterioration, and cumulative system stress. Introduction: I became overweight BMI greater than 25 around 1977, at age 30, largely due to adopting the American lifestyle combined with a prolonged overworked lifestyle, frequent business meals, irregular eating patterns, high-calorie and high-sugar food intake with large portion sizes, insufficient physical activity, and sustained occupational pressure gradually led to progressive weight gain and metabolic imbalance. By 2010, at age 63, my body weight had reached 220 pounds, corresponding to a BMI of 30.5. I was officially diagnosed with type 2 diabetes T2D in 1994 at age 47, when my glucose level reached 350 mg VL. Looking back, I estimate that diabetes likely began around 1990 at age 43, or possibly even earlier. During the following 16-year period from 1994 to 2009, my diabetes management relied primarily on medications without meaningful lifestyle modification, despite continuous pharmacological treatment. My glucose levels remained persistently high, and my metabolic condition gradually deteriorated. By 2010, at age 63, I developed severe complications, including kidney failure that required dialysis consideration, severe neuropathy that nearly resulted in toe amputation, and advanced retinopathy that nearly led to blindness. That year became a major turning point in my life and served as a critical wake-up call. I decided to cease all business and charitable activities and focus entirely on restoring my health. I chose to rely solely on strict lifestyle management and did not take any medications or supplements of any kind, including vitamins. Beginning in 2010 at age 63, I initiated systematic self-study in medicine, pathophysiology, nutrition, lifestyle details, chronic metabolic disorders, and the major mortality diseases that I had previously experienced. During the past 17 years, I have consistently devoted 13 to 14 hours per day, every day, to studying medicine, health, chronic metabolic disorders, and the major mortality diseases that I have personally experienced. In 2017, at age 70, I completed and published my first medical research paper, marking the beginning of a structured effort to document and communicate findings derived from longitudinal personal health data and interdisciplinary scientific analysis. Section 1: Why diabetes influences many mortality diseases. Diabetes primarily produces chronic exposure to elevated glucose levels. Excess glucose behaves like a slow chemical stress applied continuously to tissues throughout the body. Long-term glucose exposure includes: it damages blood vessel walls, increases inflammation, stiffens arteries, impairs immune response, accelerates biological aging of organs. From a physics viewpoint, chronic elevated glucose behaves like a continuous background stress load, which I consider a root cause, applied to the biomedical system. Over time, this persistent metabolic burden gradually weakens structural integrity and increases the probability of functional failure across multiple organs. Because blood circulation delivers glucose fuel, oxygen, and nutrients to every organ, damage to the vascular system produces widespread consequences throughout the body. This explains why diabetes repeatedly appears as a common underlying factor in many chronic conditions and mortality diseases. Section 2: Major mortality diseases strongly linked to diabetes. Cardiovascular disease, heart attack and stroke. Chronic elevated glucose damages the inner lining of arteries, endothelium, endotheli. All damage promotes plaque accumulation inside blood vessels and progressive arterial stiffness, causing blood vessels to become less elastic. These structural changes increase the risk of coronary artery blockage and stroke. either through brain vessel obstruction ischemic stroke or brain vessel rupture hemorrhagic stroke. Approximately 65% to 75% of individuals with diabetes eventually die from cardiovascular causes. Stroke ischemic, blockage type, hemorrhagic, rupture type. Diabetes contributes to both vessel blockage and vessel rupture. Chronic glucose exposure weakens vessel wall structure and accelerates atherosclerosis, artery plaque buildup, narrowing vessels. Approximately 30% to 40% of stroke patients have diabetes. Chronic kidney disease (CKD). Kidneys contain millions of microscopic filtering units called glomeruli. These filters depend on stable microcirculation blood flow in very small vessels. Chronic glucose exposure damages these microvessels, gradually reducing filtration ability. Diabetes is the leading cause of kidney failure worldwide. Approximately 40% to 50% of kidney failure cases are associated with diabetes. Dementia, brain function decline including Alzheimer and Parkinson diseases. Glucose dysregulation affects brain microcirculation and neuronal energy metabolism. Insulin signaling also plays a role in brain function. Diabetes increases risk of dementia by about 25% to 35%. Cancer moderate association. Diabetes is associated with increased risk of several cancers, including liver cancer, pancreatic cancer, colorectal cancer, breast cancer, and endometrial cancer, cancer of uterine lining. Possible mechanisms include chronic inflammation, elevated insulin signaling, and cellular growth pathway activation, signals that make cells grow faster than normal. Cancer associations typically show risk increases of approximately 15% to 40%, depending on cancer type. Section 3 Summary of estimated contribution of diabetes to major diseases. Diabetes contributes to many major disease categories with varying degrees of influence. Cardiovascular disease shows the strongest association, with approximately 60% to 75% of diabetic individuals eventually dying from cardiovascular causes. Stroke shows approximately 30% to 40% association with diabetes. Chronic kidney disease shows approximately 40% to 50% association. Peripheral artery disease shows approximately 20% to 30% association. Retinopathy develops in approximately 70% to 80% of individuals with long-term diabetes. Neuropathy develops in approximately 50% to 60% of long-term diabetic patients. Metabolic liver disease shows approximately 40% to 60% association with diabetes or insulin resistance. Pancreatic cancer risk increases approximately 25% to 35%. Colorectal cancer risk increases approximately 20% to 30%. Breast cancer risk increases approximately 15% to 25%. Overall mortality risk is approximately 1.5 to 2 times higher compared with non-diabetic populations. These percentages indicate strength of association rather than single-cause attribution. Section for metabolic disorders beyond diabetes. Diabetes rarely exists alone. It usually appears together with other metabolic abnormalities, physiological conditions, not lifestyle inputs, hypertension, dyslipidemia, visceral fat accumulation, insulin resistance. When considered together, metabolic disorders contribute to approximately 60% to 75% of major chronic disease mortality worldwide. For personal interest, based on my recent stroke case, metabolic disorders collectively contribute approximately 70% to 90% of stroke cases. A simplified estimate suggests approximately 80% to 85% of strokes are associated with metabolic and lifestyle-related abnormalities. Major metabolic contributors to stroke include hypertension 50% to 60%, diabetes 30% to 40%, dyslipidemia 25% to 35%, obesity especially visceral fat accumulation 20% to 30%. These percentages overlap because many patients have more than one metabolic abnormality at the same time. When considered together, metabolic disorders collectively contribute to approximately 70% to 90% of stroke cases. Stroke ischemic, blockage type, and hemorrhagic. Rupture type is fundamentally a vascular failure event. Long-term metabolic imbalance gradually damages blood vessel structure, making vessels more vulnerable to either blockage or rupture. This description closely reflects the physiological condition that led to my recent stroke. These factors interact multiplicatively with an amplification effect, rate then additively. Section 5 Macrovascular versus microvascular damage. Cardiovascular disease primarily involves macrovascular structures, large blood vessels, including large and medium arteries such as coronary arteries, arteries supplying blood to Heart muscle and carotid arteries. Arteries supplying blood to the brain. Heart attacks usually occur when atherosclerotic lack of fat and cholesterol buildup inside artery wall forms, becomes unstable, ruptures, and triggers clot formation that blocks blood flow. Macrovascular disease is strongly influenced by blood pressure, mechanical lipid accumulation, chronic inflammation, sympathetic nervous system activation. In contrast, diabetes strongly affects microvascular structures. Microvascular systems include kidney, glomerular capillaries, retinal capillaries, eyes, brain, microcirculation. Peripheral nerve capillaries. Chronic glucose exposure produces protein glycation, basement membrane thickening, capillary leakage, reduced oxygen diffusion. Mitochondrial stress, reduced cellular energy production. Microvascular damage typically develops gradually over many years. This is part 1.